Okay, so first off, welcome. I'm happy to have you here in the PICU, and we'll see our Practice Academy group back later. So restraints. I'm going to make this quick, but it's necessary information. In this facility, about a year and a half ago, we were made aware during our blitz, and some of you that have come from the adult hospital are likely aware of this as well, that there was a sentinel event with a developmentally delayed adult that was admitted through the emergency department on a general care floor, and it was the middle of the night, about 2 in the morning, and from 2 in the morning till shortly after 6 when family came in, the patient was in leather restraints and had quite a few medications on board. Family was upset, and the documentation to support how they got from being wheeled up and not restrained and in 4 hours being in such a state unfortunately didn't support any of what had gone on. So a complaint was made and actions were taken. So in the pediatric intensive care units, we have always felt that we wanted to keep our children safe from harm by restraining them so that they would not dislodge their tubes. And our mindset was always on safety, and we felt like we couldn't reason with a lot of our age groups. Since this greater emphasis on restraints, I can tell you that we've actually come a long way, and we think about restraints differently. I don't think that we restrained a lot of our patients in the unit, but now it was very rare that we ever had no restraints in either of our units, and we can actually say that now. We go many days every week with no restraints in our unit. So I think that it was good for us to think about what to do and alternatives to use. So the message I'd like to deliver right now is give you some suggestions for alternatives, and then if you do have to restrain, what are your responsibilities? Okay, so if you can, try and avoid restraints. Such things as socks. I don't know if you've seen all the selection of socks we have in the equipment rooms, but similar to outfits that parents can buy their young infants that have the mitts already sewn into them, you can place these on infants and young children's hands so that prevents them from actually getting hold of things or accidentally getting their fingers wound around something and pulling it out. Swaddling, developmentally appropriate, works wonders, but please keep in mind swaddling constantly 24 hours is not good for muscle development as well. But swaddling will prevent tube dislodgement and prevents placing restraints on younger children. Parents are a great opportunity. They want to be involved. They will hold a hand, constant reminders. Get them involved. Tell them that this current behavior is a safety risk. You don't want to put restraints on them. Would they mind helping you? Lots of parents are very appreciative of the opportunity. Cover your lines just with our cloth diapers. Out of sight, out of mind, especially for the toddler group that are curious about things. As far as your IVs go, IV shields, they're available in the equipment room for the peripheral IVs. Bridling the small bore feeding tubes. Have any of you had a tube with a bridle in it yet? Yes? Okay. The rapid response nurses are all skilled in placing a bridle, so you have somebody on all the time that can bridle for you, and that will definitely deter dislodgement of small bore feeding tubes. And there's sleeves available. We don't carry them on the unit as of yet, but you can order up sleeves that actually cover PICC lines, and the children can wear them, and they come in various sizes. Child Life, if you've met Joel, you know what a wonderful resource he is, and if you have somebody that's busy in the bed and will not leave lines and tubes alone, he's a great resource. So he'll give them something to do. And we also have music therapy. Any of you met our musicians yet? No? And Joel can connect that resource as well if you're busy and can't do that. So those are some suggestions of avoiding restraints. The other thing that I didn't mention is we carry these, they are commercial swaddlers, and they are right in the equipment room on the linen cart as well. So, and they're not hard to figure out how to get a baby in them. And they allow for a little more movement, which is more developmentally appropriate than when we swaddle our kids really tight with our receiving blankets. So there's different sizes. And that's a nice resource as well. So you can no longer avoid restraints. You have to accept that that's where you're going. And definitely always base it on patient safety. And definitely, you know, as I said earlier, we are in our environment challenged with the developmental stages of children. One of the biggest things to remember is once you place those restraints, you need an order in your chart within 30 minutes. You would not give a medication without checking your order. You don't put restraints on without making sure you got the order, okay? If your physician is close by, you know, encourage them to use the computer that's right in the room so that you know that it's done. Your order must be renewed every 24 hours after assessing a continued need for the restraints. Our physicians rely on us to let them know whether or not restraints are still needed. So if you're getting to the point where you think they're not needed, communicate that to them so that they don't have to renew your order. All right, so once you've gotten to the point where restraints need to be placed, you'll have to document. So when you initiate your restraints, you have to describe the alternatives that you tried prior to restraints. That's necessary. Big deal, start time. EPIC is built on start times and stop times. So a lot of things you will do have start times and stop times. So document your start time. The reason this is important is if you put your restraints on, you asked your physician for an order, and it slipped their mind, or they got busy, or something went on, be considerate of that. If you indicate, so it's 9:22 right now, if you go in and document that your restraints went on at 9 o'clock just because you were busy with patient care and you just documented all your 9 o'clocks, you have now just given your physician only but 8 minutes to get an order in. You might have not put them on until 9:15, but so give them the opportunity to use their 30 minutes. So if you put them on at 9:15, document 9:15. Don't document 9 o'clock because you are shortening their clock. And then that gets us into some trouble. Please make sure you explain to the parents and family why the child's in restraints. You have on your restraint flow sheet Q1 hour assessments, Q2 hour interventions, and Q4 hour alternatives and a treatment plan. So basically, this is newer documentation, we're being asked to, are you still considering alternatives with this child? And if not, what's the plan to get them out of restraints? I think I'll mention right here, at this point, you cannot trial restraints off on anyone. You cannot trial them off. They're on or they're off. You can certainly release them to do patient care, to turn patients, to do range of motion, to do the mobility thing, you know, where we're sitting patients up on the side of the bed and dangling, transferring into a chair. But if they're still very confused, delirious, and those sorts of things, and you can't reason with them and they're still a threat to their tubes, you may have to continue the restraint when they're up in the chair. But we cannot trial restraints off, okay? So they're on, and you have them restrained, or they're off for patient care, or you're totally discontinuing them. Written notes. So when you initiate restraints, you need to write a restraint note and describe that you've initiated. What's important in that note is, you know, we use these kinds of restraints, and what it is we plan to do to get the patient out of restraints. So you do require a restraint assessment note, so you write that initiation note in a restraint assessment note. So restraint assessment notes are required when you start restraints, when you stop restraints, and every shift. So if you are only working with that patient for 2 hours and then your assignment gets switched, you're still required to document a restraint assessment note. Thankfully, most of us, that doesn't happen. You know, it'd be a very rare event. So any number of hours of shift, up to 12 hours. After that, if you are working a 16 because you picked up a few extra hours, unfortunately, you're going to have to start over again. So if you are working a 16, which I don't think a lot of people do very often, but it does happen, and your patient is in restraints that whole time, you will have to write two notes, because 12 hours is sort of the end of what is allowed to be shift. Plan of care. The new name for them are the goal outcome evaluation note. So every 24 hours, every patient in both of our intensive care environments, PCTU and PICU, require a plan of care note. And within the plan of care note, you do have to mention restraints. And you want to mention how you plan on getting the patient out of restraints. The reason being is you are in restraints so that your treatment plan can continue. It's a component of your treatment plan. So it needs to be mentioned in your plan of care note. So if you have a patient in restraints, you will write a restraint assessment note and you will mention it in their plan of care note, if their plan of care note is due on your time, on your shift. Okay? Any questions so far? No? All right, so when you discontinue restraints, that's a good thing, less documentation. In the PICU, we recommend that you discontinue restraints when the patient is going to the OR, to IR procedure area with anesthesia. So in other words, you're not maintaining care of that patient, discontinue your restraints. There becomes a great big gap in documentation, and as you know, not every area is on Epic yet. So I strongly recommend you just discontinue your restraints when you are no longer maintaining care of that patient and they are leaving our ICU areas. Certainly discontinue your restraints when the patient is no longer a threat to their lines, their tubes. They've discontinued those, and they're not going to be a threat to those. You must you must document a stop time. If you don't document a stop time, there are triggers that go off and reports that are made, and it looks like the patient's still on restraints. So if you could remember to start and stop your restraints on your flow sheet, that'd be appreciated. Make sure your Q1 hour, Q2 hour, and Q4 hour fields are all completed. You don't want to miss your assessments for 8 o'clock and discontinue your restraints at 9:05. We do sometimes get into that difficulty because restraints are monitored very heavily by the organization. So we get into a little bit of difficulty sometimes when, you know, we write a time down of 9:05, but we didn't do the 8 o'clock assessments. So just a reminder to just make sure everything is all current and then put your stop time down. Be sure to discontinue your restraint order. You can do that. You don't have to have the physicians do that. And you will write a restraint assessment note, as I mentioned earlier. So, any questions? No? Okay. All right. A little pun, the no-nos of restraints. Have you guys had a patient with no-nos on yet? Yes? Elbow restraints is what you will find them called, elbow restraints. Yes, you probably didn't use these in the NICU. So I bring us that along, because not everybody's ever seen them, but we call them no-nos. But the correct terminology in your documentation is an elbow restraint. It is a restraint. Restraints of one extremity when the other, one upper extremity when the other upper extremity is functional is not a restraint. Okay? But however, if the other extremity is not functional, then you have just restrained your patient. So we've had children who have had strokes. One side doesn't work. When we restrain the other side, even though it's only one restraint, we have now restrained the child. Okay, and you need an order and the whole correct process for that. So we're going to talk about a couple no-nos of restraints. PRN orders are definitely no-nos. You can't have a just-in-case order. Trialing the patient with restraints to see how they do, we've discussed that already. That is definitely something we are not permitted to do. Letting the order lapse. So you are working your shift, you notice that the patient came into the unit, required restraints. It might have been at an odd time. Obviously not everyone comes in during rounds. You are required to know when your restraint order is going to expire. Just as I said, you're going to document on something, make sure you have an order for it. You wouldn't give that vancomycin without checking that order. And you wouldn't document on your MAR you gave vancomycin without knowing you had a vancomycin order. So same thing. You don't document on restraints without knowing you have a current restraint order. So please have a look at the time that it expires. If you notice it's going to expire soon, an hour or two, let your providers know. If you don't get a response, which occasionally happens, but not very often, please go up the chain of command. You know, you're welcome to call them back a second time, but if you still do not get satisfaction and get an order, then go up the chain of command, because they are not to expire. We all get busy. The ICU environment is not something that we are available to sit down on the hour and get all our hourly documentation done. With restraints, occasionally documentation gets missed because we miss the hour. So if you've gone a couple hours without documenting your restraints, look along the top of your flow sheet to make sure you have every hour, because they do drop off. You can put it back in, but they do drop off. So if you've been several hours because there's been a lot going on, please just visualize that you have every hour of the clock on your flow sheet, because they'll drop off after a bit of time. The other thing that I'd like to mention is when patients have neuromuscular blockers in place and you're utilizing those, restraints should not be necessary. All right? Violent behavior restraints, more informally known as leathers. We see them very infrequently, which is great, very infrequently. When the necessity does come to using leathers, I'm going to recommend, it's not you, likely, because you are busy with your patient. Please ask a colleague, ask myself, Tony, anyone from nursing leadership, charge nurse, to print off the policy. There's some caveats in there that are good to know. I don't expect you to remember them now because we don't see leathers very often. I will give you a couple of the real key points. Once they're applied, you need an order written within 30 minutes of application. If the child's under 9, you need an order every hour, because the idea is you're frequently assessing that patient so that hopefully you will be moving out of leather restraints quickly. If they're from 9 to 17 years, they require an order every 2 hours. It's every 15-minute assessment. There is a different flow sheet. I don't know if you've encountered that yet. We have the nonviolent behavior restraints, and we also have a violent behavior restraint tab. Few 15-minute assessments, so quite a bit of documentation with violent restraints. Few 2-hour interventions again, and the key to the leather restraints must be available in the room. A lot of people just tape it to the computer. Excuse me, tape it to the computer. But those are a few of the caveats. There's more to the policy than that. Like I said, if you're dealing with a patient in leather restraints, it's likely not you reading the policy, but you may be helping a colleague if it's your next door neighbor. And review it and make sure you can highlight the points that you want them to know, or verbally read them to them, or go in and help them with it. But because we don't see it very often, I just want you to know the resources there. So, do you guys have any questions?
Do the doctors have to visualize the patient before they write the order? Or do we need to get them to come to the bedside before they write the order for the restraints?
In the ICU, the policy says yes. In the ICU environment, because our physicians are around all the time, they have eyes on our patients, we don't necessarily make them come to the bedside because it's quite likely they've been in a room already recently. So to answer your question formally, yes, the policy does require that. And I see the necessity of that in a general care setting where physicians may not see the patient once or twice a day. In our environment, in PCTU and PICU, we have physicians available, eyeing our patients, walking through the unit all the time, helping us, answering questions.
Okay.